Very good evening, everybody. Today we are going to talk about the two short subjects. It's kind of like a break day for you, so I don't want to stress you more. So, like today we are going to talk about your short subject. From tomorrow we will do the second year subject as we discussed. Okay. So speaking about the short subject, the first session we are going to be doing the very first session we are going to be doing anesthesia. So anesthesia will be running around like 1 hour and 10 minutes. And then you have a 10 minutes of break, and then you have a dermatology which will be running from another 1 hour 10 minutes. Okay, if it goes, then it may go up to the 7:30 today or 7:45 today. So this is our session, upcoming session. So speaking about the anesthesia is kind of like a very short subject. So the score for anesthesia is kind of like like a 5 marks, but technically within with the pharmacology it includes like a 7 marks. So we cannot able to differentiate sometimes whether it's a pharmacology question or from the anesthesia question. Out of that 7 mark, if you know the anesthesia pharmacology very good, pharmacology of anesthesia very good, then you may answer up to 3 to 4 questions. 3 questions minimum you can able to answer. Okay, so this is all about that. So you may get a 3 questions, people, 3 questions out of it. And apart from that, there are certain picture-based questions that may ask you. So our target of target score for anesthesia is 3 to 4 here. So if we score 3 to 4 in the anesthesia, then it will be good. So with that, I'm going to cover you the in-depth review of your anesthesia pharmacology. In-depth review of anesthesia pharmacology, followed by the few images. Okay. So we cover within that pharmacology, we cover the basis too, so that we can able to identify, you can able to answer most of the questions. So is that clear? Is that clear? Okay. One whomsoever present here to acknowledge before I proceed to the topic. If you could hear my voice and see the screen properly, type yes on the chat box. If you could hear my voice and see the screen properly, type yes on the chat box so that I can able to proceed. One whomsoever present to acknowledge faster. So type yes on the chat box if you could hear my voice and see the screen properly. Okay, fine. So we are proceeding. We are proceeding to anesthesia. Speaking about the anesthesia, we are going to talk about first the general principles of your anesthesia. So general anesthesia, what is so-called as general anesthesia? What are the principles behind your general anesthesia? First one we are going to talk about is your stages of anesthesia, and then followed by depth of anesthesia. So speaking about the stages of anesthesia, we are having a 3 phase. One is your induction phase, another one is your maintenance phase, another one is your recovery phase. What are they? Induction phase, maintenance phase, and recovery phase. So what is the induction phase, people? From the administration of drug to the development of anesthesia is so called as induction phase. From the administration of drug to the development of anesthesia is so called as induction phase. Okay, this is the induction phase. So maintenance of your sustained anesthesia is maintenance phase, and from discontinuation of a drug to return of consciousness is a recovery phase. Discontinuation of a drug to return of consciousness is a recovery phase. So totally we are having a 3 phases. What are they? 3 phases of anesthesia. Initiation phase or the induction phase, followed by maintenance phase, followed by recovery phase. So induction phase, what is meant by induction phase? Induction phase means initiation of drug to development of anesthesia. Initiation of drug to development of anesthesia. Drug to development of anesthesia. Okay. So maintenance is maintenance and recovery is discontinuation of the drug to return of consciousness. Okay, speaking about the 3 phases, okay, the when will you see the induction phase? How long does the induction phase last for? You know, the unconsciousness should be reached within a 40 to 50 seconds. Whenever you give a induction, whenever you give the anesthesia, mainly through the IV agent, then the unconsciousness should return, reached within 40 to 50 seconds. Okay. Apart from that, what are the things you need to consider during the maintenance phase? Monitor the vital signs and look for the depth of anesthesia and look for the response to stimuli. Look for the response to stimuli, and reversal of induction will occurs in the recovery phase. Okay, will occurs in the recovery phase. So induction phase, you give an induction and you watch patient goes for unconscious. If you are giving a IV, when will the patient should go? If you are giving an IV, how long it takes for a patient to go unconscious? How long does the patient to go unconscious? It takes barely 40 to 50 seconds. It takes barely 40 to 50 seconds. And apart from that, people, in the maintenance phase, what are the things you need to consider in the maintenance phase? One is your vital sign. Another one is your depth of anesthesia. Another one is your response to stimuli. Another one is your response to stimuli. And then you have a recovery phase. Reversal of your induction phase occurs here. Reversal of your induction phase will occurs here. Now, speaking about, we monitor the vital signs like a BP, heart rate, respiratory rate, saturation, and all. We know that. So, depth of anesthesia. So, what are the stages we have in the depth of anesthesia? First, we talked about the stages of anesthesia. Now, we are talking about the depth of anesthesia. So, what are the stages we have in the depth of anesthesia? So, first is a stage 1, which is an analgesic stage, people. First is the stage 1, which is the analgesic stage where loss of pain will occur. Where loss of pain will occur. And this is the stage where the patient will move from conscious to unconscious state. Okay, this is the stage where the patient will move from conscious to unconscious stage. Okay. So what is stage 1? Analgesic, pain will be lost, and the patient move from conscious to unconscious. And stage 2 is your excitement stage, where amnesia or reduced awareness of pain are the indication of progression. Okay, indication of progression. Amnesia and reduced awareness of pain are the indication of progressions. You have to remember. Okay. Then, apart from that, you have to give us short-acting barbiturates in order to avoid the stage 2 anesthesia. Okay, stage 2 depth of anesthesia. What are the characteristic appearance in this stage? Delirium, combat behavior you may see, elevated BP you may see, elevated rate of respiration you may see, and then you see the laryngospasm. All of the discomfort stage will be seen in the case of your stage 2, which is your excitement stage. And followed by the excitement stage, you have the surgical anesthetic stage. Followed by the excitement stage, you have the surgical anesthetic stage, which is the most preferable stage of surgery. As per the depth, what is the most preferable stage of your surgery? Stage 3 of depth of anesthesia. Okay, stage 3 of depth of anesthesia. And stage 3 is further divided into 3 planes. Among that, the best stage for surgery is stage 3, plane 3. Very, 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 very important MCQ. Let me put it in the red. Let me put it in the red. Very, 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 very important MCQ. Stage 3, plane 3 is a preferred best stage for your surgery. Okay. So preferred best stage for your surgery is stage 3, plane 3. And what are the characteristics you may see here? The characteristics you may find here are your CNS depression. The characteristics you may find here are CNS depression, and rate of respiration should be back to normal. And then you have the muscular relaxation, and then you have a loss of spontaneous movement. And then you have a loss of spontaneous movement. So here, excitation stage, here, suppression stage. CNS depression may happen here. Then you have a stage 4, which is a medullary paralysis stage, which is a medullary paralytic stage, and which is considered to be the severe or in-depth stage of anesthesia. Severe or in-depth stage of anesthesia, and there is a possibility of death occur in the stage 4 if you haven't managed properly. If you haven't managed properly, then there is a possibility of death may occur. Okay. So it is not regular stage and the critical management is required. So best the patient may undergo surgery in the stage 3 and patient may come out in the stage 3 itself. Okay. And how do you select the pre-operative drugs? It should relieve the anxiety and it should induce the amnesia. For example, we give a short-acting barbiturates, right? Yes or no? We give a short-acting barbiturates. Why are we giving? To remove the stage 2, to create the amnesia on the patient. Yes or no? To forget the stage 2. Apart from that, it may cause a decrease of saliva and the gastric juices so that it may not complicate the surgery. And one which increases gastric pH. And, for example, like H2 blockers you can give so that your patient may not have any ulcers. And apart from that, you may give a pre-medications. The time to give the pre-medications is 30 minutes to 2 hours prior to anesthesia. 30 minutes or 2 hours prior to anesthesia. Okay, now speaking about the selection of anesthesia, people. Speaking about the selection of anesthesia. So how do you select the anesthesia? So anesthesia is selected based upon site of surgery, whether the patient is undergoing a neurosurgery or not, whether the patient is undergoing a simple abdominal surgery like inguinal hernia repair or not, or the patient is undergoing a very complicated thoracotomy. Depending upon the site of surgery, you may have the selection of anesthesia. And then positioning of patient, what position that the patient may be, and then concurrent disease, elective or emergency, apart from that age, and then you have to ask the patient preference. But for example, some people don't prefer the general anesthesia IV. So you have to give the inhalational for him. So depending upon that, you have to give the anesthesia. So we have talked about the stage of anesthesia and we talked about the depth of anesthesia. So what are the stages of anesthesia, people? So what are the stages of anesthesia? We are having 3 stages of anesthesia. What are they? One is your induction phase. Another one is your maintenance phase. Another one is your recovery phase. Another one is your recovery phase. What is induction phase? From the administration to the development. From the administration of drug to the development of your anesthesia. Okay, and the stage 2 is the maintenance. Well, stage 3 is, what is stage 3, people? Stage 3 is a discontinuation of a drug to return of consciousness. Discontinuation of a drug to return of consciousness. Okay. So the main area of interest where we have to monitor is your stage 2, which is your maintenance phase, where you may see vital signs and depth of anesthesia and response to the stimulus. All 3 should be monitored continuously. All 3 should be monitored continuously. Then you have a depth of anesthesia. Speaking about the depth of anesthesia, stage 1 is your analgesic stage, where the patient is moving from conscious to unconscious stage. And the stage 2 is excitement stage, where you can avoid the stage 2 by giving him a short-acting barbiturate, because the characteristic feature of your stage 2 is like, excitement stage. Since it is excitement stage, patient may develop a combat behavior or maybe delirium or elevated BP or elevated rate of respiration or laryngospasm. Many of these conditions may be seen. Okay, so analgesic stage, excitement stage, and then you have a surgical anesthetic stage. And then you have the surgical anesthetic stage, which is a most preferable stage for surgery. And the best stage of surgery, best anesthetic stage of surgery is stage 3, plane 3. Very, 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 very important MCQ. Medullary paralytic stage is also known as stage 4. Medullary paralytic stage is also known as stage 4. Okay, how do you maintain the general anesthesia? By giving an analgesia. Narcotic combines with the other agents or unconsciousness. Depth of anesthesia must be monitored. And the skeletal muscular relaxation should be given in a proper dose. And the control of your sympathetic nervous system response is also an important thing. You have to do it on your, in order to maintain your general anesthesia. Okay, so speaking about the general anesthesia, the very first one we are going to talk about is your inhalational anesthesia, people. The very first one we are going to talk about is your inhalational anesthetics. So speaking about the inhalational anesthetics, here comes the important MCQ, people. So what is the mode of induction? Mode of induction is via the Boyle's mission. Mode of induction is via the Boyle's mission. What mission? Boyle's mission. Okay. Then, and most of the anesthetics are stored in the cylinder. Most of the anesthetics are stored in the cylinder. So here we are going to talk about the important cylinders, their colors and their pin index, people. So what are we going to talk about here? The important color codings and important pin index of the more and important drugs which may be present in the cylinders. Okay. So given the topic of anesthesia of cylinders in the anesthesia is quite like a 5-star to 7-star rated topic where you have to remember every single thing, people, where you have to remember every single thing. So how does the cylinder to be? It has to withstand your high pressure. For the properties of cylinder, first thing is, how does the cylinder is to be? It has to be withstanding the high pressure. For that, molybdenum will be added, and then you have a low weight cylinders are preferred. So chromium can be used and attached with the pin index safety system. Okay, attached with the pin index safety system. So what should be the characteristics of the cylinder? One, it should withstand the high pressure, so molybdenum will be added for this. And second, the cylinder should be of low weight, so chromium will be added for this. And then you have the pin index safety system, which should be attached on the cylinder to avoid any error. So speaking about the color code, the first one is your orange cylinder. So speaking about the color code, the first one is your orange cylinder. So orange cylinder is for cyclopropane. Orange cylinder is for cyclopropane. This is a 7-star rated topic, people. You have to remember. Orange color cylinder is for cyclopropane, where the pin index is 3.6. Where the pin index is 3.6. And the blue cylinder is for nitric oxide. Blue cylinder is for N2O. Blue cylinder is for N2O. And then the pin index is 3.5. Pin index is 3.5. And a gray body with the white top is for air. Gray body with the white top is for air, while the pin index is 1.5. And a blue body with the white top is for Entonox, where the pin index is 7. And a black body with the white top is for O2, where the pin index is 2.5. And a gray body is for carbon dioxide. Gray body is for carbon dioxide, where the pin index is 1.6 if it is more than 7.5%, and 2.6 if it is less than 7.5%. Okay, and then you have a brown. Brown is for helium, and then brown is for helium. So here is the picture-based question. Brown cylinder is for helium, and you have the gray cylinder, and you have the gray cylinder is for air, and then black cylinder with the white top is for oxygen, gray with the white top is for air, and blue with the white top is for Entonox, and then brown cylinder is for helium, and then you have the gray cylinder is for carbon dioxide, and then you have a and then you have an orange cylinder is for cyclopropane. Okay, so now let me put you up here. Now let me put you up here with the pin index. So I tell the cylinder, you have to give me the pin index here. You have to give me the pin index here. So first one is oxygen, people. So what is the pin index of oxygen? What is the pin index of oxygen? What is the pin index of oxygen? It's a 2.5 or 2.5. What is the pin index for nitric oxide? For nitrous oxide? That is a N2O. What is the pin index for nitrous oxide? That is 3.5 or 3.5. What is the pin index for air? What is the pin index for air, people? That is a 1.5 or 1.5. And for carbon dioxide, if it is more than 7.5%, what? 1.6. If it is less than 7.5%, then it is what? 2.6. And pin index is very much high in Entonox, where the value is 7. Where the value is 7. Then what are the types of your breathing circuit we are having? We are having 3 types of breathing circuit, people. One is your open, another one is your semi-closed, and the third one is your closed breathing circuit. So what are they? open, semi-closed, and closed breathing circuits. So open breathing circuit, which is your ether or chloroform, and ethyl chloride will be used over here. Ether, chloroform, and ethyl chloride will be used on the open circuit, while semi-closed circuit is so-called as Mapleson circuit, where it is divided from type A to type F, where it is divided from type A to type F, which is a Mapleson circuit, which is a semi-closed circuit, people, which is a semi-closed circuit. So type A, which is your Magel circuit, type A, which is a Magel circuit, which is a circuit of choice for spontaneous ventilation. Very, 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 very important MCQ, people. Type A is for spontaneous ventilation. Type A or Magel circuit is for spontaneous ventilation. While type B and type C, which is a waters, which is not used nowadays, and type D is a Bain, which is the most commonly used one, and it is for a controlled ventilation. Very, 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 very important is your Bains. Okay, in ICU setup, we use mostly the Bains. Okay, so Bains is for controlled ventilation, and Bains is the most commonly used circuit. Bains is the most commonly used circuit. And type E is Iris TPs, which is for pediatric, and type F is also pediatric, which is a Jackson-Rees. So what are the Maples and type A to F? Type A is also known as Magels. Type B do not have any other name. Type C is Waters. Type D is Bains. Type E is ISTPs, and type F is Jackson-Rees. So what are they? Type A is, type faster, people. Type A is Magels. Type C is Waters, and type D is Bains. Type E is ISTPs. Type F is Jackson-Rees. Among the pediatric circuits, where type E and F. Among that, which one we use for controlled ventilation? Type D or Bains. Among that, we have the which one is used for the spontaneous ventilation? Type A or Magels. Type A or Magel circuit we use for spontaneous ventilation. Bains is for controlled ventilation. ISTPs and Jackson-Rees is for pediatric circuit. Okay, is for pediatric circuit. Then you have a closed breathing circuit, which is useful for the non-useful gases like trilane, sevoflurane, and methoxyflurane. And the useful gases ones in the closed circuit are soda lime and berry lime. Soda lime and berry lime. So this is a picture of your Mapleson circuit. Type A to type F. Type A to type F is your Mapleson circuits. So where FG is a fresh gas and P is for the patient. P is for the patient. So we have talked about all of them. So now here I want to highlight you the important things. So type A, Magels. Type A is for Magels, which is for spontaneous circulation. Sorry, spontaneous ventilation. Ventilation. And type D is Bains. Type D is Bains, which is for Bains is for controlled ventilation. Bains is for controlled ventilation. And E and F, which is your ISTPs and Jackson-Rees, both is for pediatric. Pediatric spontaneous circulation. Our pediatric circuit, we use this Mapleson E and F. We use this Mapleson E and F. So whenever you give an inhalational anesthetic, now we talked about what are the routes which has been given on the inhalational anesthetic. Now, speaking about the inhalational anesthetic, what are the systemic effect of your inhalational anesthetic? What are the systemic effect you may see in the inhalational anesthetic, people? So first one is your respiratory system. First one is your respiratory system. All of them are bronchodilators. All of them are bronchodilators, and all of them are respiratory system suppressors. So bronchodilation and respiratory system suppression. Respiratory system suppression. RS suppression. Except ether, which shows a stimulation in the respiratory system. Okay, exception is ether. Okay, which shows a stimulatory activity, Okay, apart from that, you have a cardiovascular system, reduction in cardiac output, where you may see the pulmonary vasoconstriction and inhibition of your baroreceptor and reduction of BP, exception is cyclopropene. And for cardiovascular system, agent of choice is isoflurane, and halothane can cause arrhythmia. So cardiac output, BP, both are reducing here, and BP reduction, exception is cyclopropene, which can able to rise your BP. One point, which is very important point. Okay, and apart from that, inhibition of baroreceptor reflexes and pulmonary vasoconstriction, and arrhythmias by halothane, So halothane causes arrhythmias, and then you have a cyclopropene causes elevated BP, and isoflurane is an agent of choice in the cardiovascular system. All of them causes respiratory suppression. Exception is ether, which shows a stimulatory action. And then you have a renal system, which is a fluoride accumulation on the kidney. So fluoride accumulates on the kidney and nephrotoxic, mainly by your methoxyflurane. Methoxyflurane is contraindicated in renal failure patients. So you can give an inhalational anesthetic except the methoxyflurane in terms of renal action, because it is a renal toxic, and it is a nephrotoxic, and it is contraindicated in renal failure patient. And sometimes this fluoride accumulation can damage your kidney. Okay, then hematology, vasodilation, and bone marrow suppression, and megaloblastic anemia. Vasodilation, bone marrow suppression, and megaloblastic anemia are the common complications of your, or common systemic effect of your inhalational anesthetic. Then apart from that, CNS, elevated ICP, and elevated cerebral oxygen consumption. And then hepatobiliary, which is a hepatotoxic, where the drugs such as halothane and methoxyflurane, etc. will be there. Okay, drugs such as halothane and methoxyflurane will be there, and it is a hepatotoxic one. And apart from that, what are the classification of general inhalational anesthetic? So we classify the general inhalational anesthetics into 3 types: halogenated ether, alkane, and gaseous anesthetics. Halogenated ether, alkane, and gaseous anesthetics. So halogenated ether ones are 4: isoflurane, sevoflurane, desflurane, and enflurane. Okay, isoflurane, sevoflurane, desflurane, and enflurane. I used to remember with the mnemonic of SEED. SEID, SEED. Okay, and then alkane is a halothane, while gaseous anesthetic is your nitric oxide and xenon. Nitric oxide and xenon is your gaseous anesthetics. So far we have talked about the inhalational anesthetic. What are the routes we are available? What are the instruments we are delivering the inhalational anesthetic? What are the systemic side effects? Okay, yes or no? What are the systemic side effects? One is your respiratory system, which of them are bronchodilators, and all of them are respiratory system suppressors. Exception is ether. And for cardiovascular, it will decreases the cardiac output. It will decreases the BP except cyclopropene. And agent of choice in the cardiovascular is always isoflurane, and arrhythmia is caused by halothane. Renal system, methoxyflurane is a nephrotoxic one. Okay, hematology, vasodilation, bone marrow suppression, and it may also cause a megaloblastic anemia. Then you have a CNS, where you see the elevated ICP and elevated cerebral O2 consumption. Then you have a hepatobiliary, which is hepatotoxic, and drugs such as halothane and methoxyflurane are hepatotoxic. Okay, so for respiratory, bronchodilation, respiratory suppression, reduction in cardiac output, reduction in BP, exception, cyclopropene. Reduction in respiratory suppression, exception, ethane. Okay, then nephrotoxic, methoxyflurane, and hepatotoxic, halothane, methoxyflurane. Okay, and CNS effect, elevated ICP. Hematology effect, vasodilation, bone marrow suppression, and megaloblastic anemia. So we have talked about the circuit, the delivery system, the cylinders, and then now we are going to talk about the anesthesia classification, inhalational, general anesthesia. So general anesthesia, inhalational classification we are seeing. So first one is it is classified into 3 types, namely halogenated ether, gases, and alkanes. Halogenated ether, gases, and alkane. And speaking about the halogenated ether, remember with the mnemonic of SEID, seed, isoflurane, sevoflurane, desflurane, and enflurane. Isoflurane, sevoflurane, desflurane, and enflurane. While the gaseous ones are nitric oxide and xenon, while the alkane ones are halothane. Okay, fine. Among that, first we talk about the halogenated ether. So SEID, we talk about it. Enflurane, desflurane, sevoflurane, isoflurane. So among that, from the last we come enflurane. So speaking about the enflurane causes tonic-clonic seizure. Enflurane causes tonic-clonic seizure, very, very important MCQ. And it is contraindicated in epileptic patient and renal failure patient. Epileptic and renal failure patient, it is contraindicated. Another important MCQ. So 3 points about enflurane: tonic-clonic seizure, contraindicated in epileptic patient and renal failure patient. Then desflurane, which is the fastest acting one, fastest acting one, lowest MAC value, very, very important MCQ, lowest MAC value. And you have the indication, anesthesia of choice in the obese patient, elderly patients, and daycare surgery. Anesthesia of choice in obese patient, elderly patient, daycare surgery. And induction side effects could result in coughing, breath holding, and laryngospasm. Side effects are coughing, breath holding, and laryngospasm. And the side effects are similar to isoflurane, except it does not cause coronary steal syndrome. Very, very important MCQ. It does not cause coronary steal syndrome. So far, this is the one. So enflurane and desflurane. So enflurane, it is so the main thing is it can cause a tonic-clonic seizure. It is contraindicated in 2 patients, epileptic patient and renal failure patient. And desflurane, fastest acting one. And then it is anesthesia of choice in obese patient, anesthesia of choice in elderly patient, and anesthesia of choice in daycare surgery. Anesthesia of choice in daycare surgery. Apart from that, you have a side effects. Side effects are similar to isoflurane, except the fact is it does not cause coronary steal syndrome. It does not cause coronary steal syndrome. Then you have a sevoflurane and isoflurane. So sevoflurane is a analgesic, poor analgesic. So anesthesia of choice in for induction in children. So elderly patient, obese patient, and daycare surgery, it is desflurane. Children, it is sevoflurane. Okay, and it is contraindicated. So in a low flow, in a closed circuit, it is contraindicated in closed circuit. Okay, and apart from that, you have isoflurane. Isoflurane is used for daycare surgery, pheochromocytoma, and cardiac surgery, and neurosurgery, and controlled hypotension. Among that, it is the inhalational choice of anesthesia in controlled hypotension and cardiac surgery. Controlled hypotension and cardiac surgery. So far we have done with the main ones. So far we have done with the main one, and the side ones are like a methoxyflurane, trichloroethylene, and cyclopropane, and then you have a ether. Okay, and then you have the ether. Methoxyflurane is having a least MAC value, and it is contraindicated in closed circuit and renal failure. And then trilene or trichloroethylene, which is anesthesia of choice in a labor and most potent anesthesia. Most potent inhalational general anesthetic is your trilene or trichloroethylene, and it will form a dichloroacetylene and can cause or damage your cranial nerve 5 and 7. It can damage your cranial nerve 5 and 7. So trilene or trichloroethylene. Okay, then you have a cyclopropane. So cyclopropane is anesthesia of choice in hemorrhagic shock. Put it in the orange cylinder, and the side effect includes cyclopropane shock and sympathetic stimulation. Now, apart from that, you have a ether having a Goodell staging, 4 staging of ether. And apart from that, it have a variety of systemic side effects, and all the side effects are similar to that of your, general inhalational anesthetic systemic effects. And main important one is it is contraindicated in diabetes mellitus. Main important one is it is contraindicated in diabetes mellitus because it can cause a hyperglycemia. Now, anesthesia of choice in obese patient, elderly patient, and daycare surgery. Elderly and daycare surgery. Daycare surgery, which is your desflurane. Which is your desflurane. Okay. Then anesthesia of choice, or the one which is contraindicated in closed circuit, is sevoflurane, and anesthesia of choice in cardiac surgery and controlled hypertension. Inhalational anesthesia of choice and AOC in cardiac surgery. And controlled hypertension patient. What is that? Anesthesia of choice in cardiac surgery and controlled hypertension is, what is that? What is that, people? That was a isoflurane. Isoflurane. And apart from that, you have this methoxyflurane. And anesthesia of choice in labor is your Trilane. Anesthesia of choice in your labor is your Trilane. And apart from that, you have a anesthesia of choice in hemorrhagic shock. In labor, it is Trilane. And anesthesia of choice in the hemorrhagic shock, it is cyclopropane. In hemorrhagic shock, it is cyclopropane. And ether is contraindicated in DM patient. This is contraindicated in DM patient, type 2 DM patient, because it can cause hyperglycemia. While desflurane side effects are similar to isoflurane, except it does not cause coronary steal syndrome, while the isoflurane will cause coronary steal syndrome. Hence, the cardiac monitoring is required for isoflurane. So we have talked about the halogenated. We have talked about the halogenated ether. Now we are going to talk about the alkane, and then we are going to talk about the gases. Now we are going to talk about the alkanes, and then we are going to talk about the gases, so that we can able to finish inhalational general anesthesia. Speaking about the alkanes, the first one is your halothane. Halothane is the inhalational anesthesia of choice and internal version of labor, manual removal of placenta, bronchial asthma, and then bronchial asthma. Apart from that, the side effects are chills and shivering, which is treated by pethidine, and malignant hypothermia, which is treated by dantrolene. Very, 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 very important MCQ, people. What is a drug which treats the malignant hypertension caused by your halothane? One is your dantrolene. And chills and shivering, that is by your pethidine. Very, 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 very important MCQ. And it is contraindicated in normal labor. What is the anesthesia of choice in the normal labor? Anesthesia of choice in the labor, Trilane. Very good. Trilane. Okay, now contraindications are pheochromocytoma, cardiac diseases, and normal labor. It is contraindicated. So halothane, inhalational anesthesia of choice and manual removal of placenta, internal version of your labor, and inhalational anesthesia of choice and what? What is the third one, people? What is the third one? Bronchial asthma. What is the third one? Bronchial asthma. Okay. Apart from that, you have a contraindications. It is contraindicated in normal labor, pheochromocytoma. Normal labor and pheochromocytoma. So with that, we have covered your halogenated ether, and then we have covered about your alkanes. Now the next area of interest is your gases. So speaking about the gases, first one is your nitrous oxide. So nitrous oxide, N2O, So speaking about the N2O, it is an inert gas and it is stored in the blue cylinder. We have already discussed that. Okay, it is stored in the blue cylinder and it is a weak anesthetic and good analgesic. Weak anesthetic and good analgesic, and it is a contraindicated in most of the conditions, people. So tympanoplasty, middle ear surgery, laparoscopic surgery, acute intestinal obstruction, valvulus, pneumothorax, pneumoperitoneum, and ophthalmic surgery. Everything it is contraindicated. And side effect, speaking about the side effect, it is causing a methemoglobinemia and laryngospasm, bone marrow suppression, and megaloblastic anemia. Remember, nitric oxide will be excreted mainly through the lungs and skin. Okay, lungs and skin. Since it is excreting through the lungs and skin, it can able to cause a diffuse hypoxia or diffusion hypoxia when recovery. Okay, you have to understand that the nitrous oxide will be excreted in the skin and lung, so that it can able to cause your diffusion hypoxia during the recovery period of time. Apart from that, you have a xenon, which is a colorless and odorless, which is mainly excreted through the lung. So hence it may cause a depression, respiratory depression, and it should be used to cause with the COPD, obese and premature patient. We have done with all the inhalational anesthetic, people. We have done with all the inhalational anesthetic. Okay, inhalational general anesthesia we have done. So halogenated ether, alkane, and then gaseous anesthetic. So halogenated ether, we have covered your isoflurane, sevoflurane, desflurane, enflurane, cyclopropane, methoxyflurane, and ether. Okay, while here alkanes, you covered about the halothane, and in the gaseous substance, we covered about the nitrous oxide and xenon. Speaking about the nitrous oxide, it can produce a diffusion hypoxia during the recovery. And isoflurane, important side effect is coronary steal syndrome. Isoflurane, important side effect is coronary steal syndrome. And desflurane is anesthesia of choice in elderly patient, obese patient, and in daycare surgery. Elderly patient, obese patient, and then daycare surgery. And then you have alkane, which is your halothane. Speaking about your halothane is an inhalational anesthesia of choice in internal version of labor, manual removal of placenta, and bronchial asthma. So this is all about your inhalational general anesthesia, people. This is all about your inhalational general anesthesia. Now we are going to talk about your intravenous anesthetics. Which should be classified into two types, namely fast-acting and slow-acting. Among that, we are going to talk about the first one is your fast-acting drug. Now, speaking about the fast-acting drug, the first one is your thiopentone. Which is an ultra-short-acting barbiturate. So ultra-short-acting barbiturate, since it is a barbiturate, it will enhance the GABA activity. Yes or no? It will enhance the GABA activity. And you know the action, it is a central nervous system. It is an anti-epileptic, anti-convulsant, and anti-analgesic. And musculoskeletal system, it can produce a twitching. And it can produce a cough and hiccup. And speaking about the respiratory system, it can cause a respiratory depression and upper airway obstruction. Among the thiopentone is the IV anesthesia of choice in neurosurgery and head injury patient, and it is an IV anesthesia of choice in thyrotoxicosis. So two things, people: thyrotoxicosis and then neurosurgery and head injury patient. It serves as a IV anesthesia of choice. Then side effects. Speaking about the side effect, it can able to precipitate your delta ALA synthase, hence it is contraindicated in acute intermittent porphyria patient. Very classical integration. Very classical integration. So what does the delta ALA synthase is doing? It is combining a succinyl CoA and glycine and converts into delta ALA, delta amino levulinic acid. Yes or no? So it is inhibiting this enzyme. So hence it is contraindicated in acute intermittent porphyria patient, and it can produce a laryngospasm. And accidentally, if you put an arterial line, then it can produce as a gangrene. In that particular area. So first one is your thiopentone. So what are the things you have to know about your thiopentone? One is your ultra short acting barbiturate, and it is an enhancement of GABA activity. It can produce twitching, cough and hiccup, and respiratory suppression and upper airway obstruction. And it is used as an IV anesthesia of choice in neurosurgery, head injury, thyrotoxicosis. Neurosurgery, head injury, and thyrotoxicosis. Side effect, delta ALA synthase, it can inhibit. So hence it is contraindicated in AIP patient. It can precipitate delta ALA synthase enzyme. Apart from that, it can produce as a laryngospasm, accidental injury, accidental injection in the intra-arterial site can produce your gangrene formation. Apart from that, you have a methotrexate. Mechanism of action is similar to thiopentone, but it is a more potent, and it is an IV anesthesia of choice in electroconvulsive therapy. IV anesthesia of choice in electroconvulsive therapy. Okay, methotrexate. Okay, what is the IV anesthesia of choice in electroconvulsive surgery? Which is supposed to be your methotrexate. Apart from that, propofol, which is kind of like a milky white powder, and it serves as an antiemetic. It is an antipruritic. It can produce symptoms similar to that of your thiopentone, like a myoclonic jerking, twitching, respiratory depression. These symptoms are similar to your thiopentone, but apart from that, it can also serve as an antiemetic, antipruritic, and it can also produce very important side effect, propofol infusion syndrome. And apart from that, propofol infusion syndrome, propofol is a IV anesthesia of choice in daycare surgery, sedation, malignant hyperthermia, and total intravenous anesthesia, TIVA. Okay, so it is a IV anesthesia of choice in 4 conditions: daycare surgery, sedation, malignant hyperthermia, and TIVA, total intravenous anesthesia. So what are the criteria we have for the propofol infusion syndrome? Rate of infusion is exceeding more than 4 mg per kg per hour for 48 hours. It can produce as a propofol infusion syndrome. While the characteristic features are metabolic acidosis, refractory bradycardia leading to asystole, rhabdomyolysis, hyperlipidemia, cardiomyopathy, and skeletal myopathy. Apart from that, you have a etomidate, which is a IV anesthesia of choice in aneurysm surgery and cardiac disease, and it can produce a respiratory depression and vomiting, nausea, and myoclonus and vitamin C def. Etomidate can produce vitamin C def. Okay, then you have a ketamine. Dosage of ketamine is 2 mg per kg. Mechanism of action is your NMDA receptor blocking. So drugs such as even like a memantine is also one of the NMDA receptor blocking activity drug, which we uses for the treatment of your Alzheimer's disease as well as your Parkinson disease. But now we are using a ketamine, which is an NMDA receptor blocking activity for your anesthesia, IV anesthesia, and your ketamine is a IV anesthesia of choice and emergency anesthesia with the full stomach. Whenever the patient is with the full stomach, then you can do the IV anesthesia of choices, ketamine, or in shock, or in induction of anesthesia in children, and induction of anesthesia in asthma patient. Induction of anesthesia in children and induction of anesthesia in asthma patient. So what are the IV anesthesia in the asthma patient? Which is your ketamine. Okay, induction of anesthesia in the asthma patient is your ketamine. And what are the anesthesia of choice? Inhalational anesthesia of choice in the bronchial asthma. Inhalational anesthesia of choice in the bronchial asthma. Go back, people. Go back. Go back to here. Halogenator. Alkane. Go back to alkane. Halothane. So halothane is an inhalational anesthetic of choice in bronchial asthma, while ketamine is a IV anesthesia of choice in bronchial asthma. Apart from that, induction of anesthesia in children is your ketamine. Okay, IV anesthesia of choice of induction in children is your ketamine. And now remember, there is one more point here. So speaking about that, the important point here is you have to remember a few things, people. One is, what circuit is a pediatric circuit? We talked about the semi-closed or Mapleson circuit in the anesthesia. What circuit is a pediatric circuit? Type E and type F. Yes or no? Type E and then type F are the pediatric circuit. And among that, what circuit is used for the controlled ventilation? What circuit is used for controlled ventilation? What circuit is used for controlled ventilation? It's a Baines, which is a type D. And type C is also known as Waters. Type C is also known as Waters. Spontaneous circulation, Magill's are type A. Magill's are type A we uses. Okay. And ketamine is IV anesthesia in most of the condition, but ketamine can cause elevated ICP and elevated IOP, people. So elevated ICP and elevated IOP, ketamine can cause. So hence it is contraindicated in head injury patient or hydrocephalus patient. Now, speaking about the benzodiazepine. So benzodiazepine is also enhancing the GABA activity. Enhancement of GABA activity. And apart from that, all of them are hypnotic as well as anticonvulsant. Among that, midazolam is an ultra short acting BCD, which we are using it for the daycare surgery. Apart from that, certain opioids are there. So opioids, fentanyl is used for the neuroleptic analgesia. And what are the drugs we used for the daycare surgery? I used to remember with the mnemonic of Indian doctor makes sick people mind active. So I stands for isoflurane, D stands for desflurane, M stands for midazolam, S stands for sevoflurane, and P stands for propofol, and M stands for mivacurium, and A stands for alfentanil. So Indian doctor make sick people's mind active. So isoflurane, desflurane, and you have a midazolam, and then sevoflurane, propofol, and then you have this mivacurium and alfentanil. All of these drugs are used for the daycare surgery. Apart from that, you have a droperidol, which is your D2 receptor blocking activity. So it can cause us extrapyramidal symptoms, and it can produce it is used for the treatment of neuroleptic analgesia and anesthesia. Along with the fentanyl. So this is all about your general anesthesia, people. This is all about your general anesthesia that you have to know. Okay. Now speaking about the local anesthesia, which is quite easy. Local anesthesia is mainly for the site of administration. So it could be either a topical or parenteral one. So local anesthesia could be of amide or esters. So we combinedly read the uses of amide, esters, and the other one. And then speaking about the amides, The main amide we use here is your lidocaine or xylocaine, which is the most commonly used local anesthetic, which is used for the regional nerve block and the spinal nerve block. And then it is also used as an antiarrhythmic one. It is also used for the antiarrhythmic one. Apart from that, bupivacaine is a long-acting used for the post-op analgesia, obstetrical epidural anesthesia, and then good analgesia and spinal anesthesia. Good analgesia and spinal anesthesia is a bupivacaine. Apart from that, you have esters. In the esters, you have a cocaine. Cocaine is used for the local anesthetics and your topical surgeries. For example, like ear surgery, nasal surgery, and ocular surgeries. Those are the surgeries where we use a cocaine. Now, the abuse of your cocaine is common, but it is very, very, like illegal. But clinical usage of your cocaine is only for local anesthetic in your topical surgeries. Apart from the benzocaine is a PABA derivative, again, topical surgeries. Procaine is combined with the phenylephrine in the dental cartridges, and it is also a local anesthesia of choice in malignant hyperthermia. Then chlorprocaine, which is similar to your procaine, which has a more potency. And then you have a tetracaine, which is used as a topical anesthesia and also used as a spinal anesthesia. Okay, and also used as a spinal anesthesia. So these are the things we talk about the uses of your esters, and then you have your amides. Then speaking about that, you have the procaine and lidocaine and prilocaine. The combination mixture cream was there, which is the topical anesthetics, which is your EMLA cream, which can be placed on the intact skin, Okay. In the local anesthesia, the last category of drugs we are seeing is your skeletal muscular relaxant, where it acts and block your NM receptors. It can act and block your NM receptors. So this NM receptor blockers could be of two types, either a depolarizing blockers or non-depolarizing blockers. Depolarizing blockers, the very, very important one is your succinylcholine. Succinylcholine, it is an ultra short acting, so good for a short-term procedures. But it can cause a elevated IOP, hyperkalemia, and malignant hyperthermia and myoglobinuria. So elevated IOP, hyperkalemia, malignant hyperthermia, and myoglobinuria are the side effect of your succinylcholine, which is a depolarizing blockers, NM blockers. Okay, and apart from that, you have all this curariform, pancuronium, rocuronium, vacuronium, saxacurarium, mivacurium, all those curium or tubercularin, all those curare is a non-depolarizing blockers. Okay, and it can be reversed by giving your acetylcholinesterase inhibitors like your physostigmine or neostigmine. It can be reversed by physostigmine or neostigmine. Okay. Apart from that, we are using certain pre-op and post-op analgesia. We can use some adjunct medicines like meperidine, morphine, and ketorolac, and so on. That is not necessary. So whatever we have seen till now was the pharmacological perspective and important anesthetic principles and your circuits, people. Important anesthesia principles and your circuits. And now what we are going to talk about is your important image-based question that may be asked to you. So number one is your Murphy's eye in your ET tube. The part of your ET tube is your Murphy's eye, where you see in the side of your ET tube and functions as a airway vent. Okay. Then oropharyngeal tube, and you have the oropharyngeal airway selection, nasopharyngeal airway insertion, and you have an anatomical anesthesia face mask, and then you have a Baines, bag and wall mask, and then RAE tube, and then you have the laryngeal mask, and then you have here the Macintosh laryngoscope, and then you have here the Macintosh laryngoscope. So these are the important image-based questions that you may expect to see in the anesthesia, people. Okay, important image-based question that you may expect to see in anesthesia. So shall we revise it completely? Shall we revise it completely? Yes. Okay. Now speaking about that, which stage is the most preferable stage for surgery as per the stages of depth of anesthesia? Stage 3, plane 3. Among that, stage 2 of your depth of anesthesia can be avoided by injecting short-acting barbiturates because it is a stage of excitement. And then stage 1 is analgesic, stage 2 is excitement, stage 3 is your surgical anesthetic, and stage 4 is your medullary paralytic. Stage 4 is the abnormal stage and it can cause death if it's not properly managed. Okay, and apart from that, you have the inhalational anesthesia. Orange color cylinder is for cyclopropane. Pin index is 3.6, and a gray body with the blue cylinder N2O. Pin index is 3.5. Gray body with the white top air 1.5. Blue body with the white top Entanox 7. Black body with the white top 2.5. Gray CO2 1.6 if it is more than 7.5, and less than 7.5 it is 2.6. Then you have a brown, which is a helium one, And breathing circuit, Maples and A, Magills for spontaneous ventilation. Maples and C, it is a Baines for controlled ventilation. D is for controlled ventilation, which is Bain. C is a water. Now it's not used in nowadays. And then you have a E and F, OIS, TPs and the Jackson Rees. Both are a pediatric one. People. Okay, you have to know that. And apart from that, you need to know the systemic side effect. All of them produces, respiratory suppression, except people. All of the inhalational anesthetic could produce respiratory suppression, except ether. All of the inhalational anesthetic can produce reduction in BP, except cyclopropane. All of them is mainly all of them are the main important one, which is nephrotoxic, is methoxyflurane. And a hepatobiliary system, it is a hepatotoxic one. Drugs are halothane and methoxyflurane. Then halogenated ether, N-fluorine, desflurane, sevoflurane, isoflurane, N-fluorine, tonic-clonic seizure and contraindicated in renal failure patient. Anesthesia of choice in obese, elderly, daycare, it is desflurane. Anesthesia of choice for induction in children, it is a sevoflurane. Cardiac surgery and controlled hypotension, then it is a isoflurane. And apart from that, you have a anesthesia of choice in labor, it is Trilene. Anesthesia of choice in hemorrhagic shock, it is cyclopropane. Goodell's 4 staging is seen in ether. Okay, and apart from that, ether is contraindicated in diabetes mellitus patient. Ether is contraindicated in diabetes mellitus patient. Inhalational anesthesia of choice in internal version of labor and manual removal of placenta. Bronchial asthma is halothane. Apart from that, the chills caused by your bronchial halothane is reverted by pethidine. Malignant hypothermia caused by your halothane is reverted by dantrolene. Okay. So apart from the nitrous oxide is stored in blue cylinder, and it can cause a diffuse hypoxia during recovery because it excreted through lungs and the skin, and it is having a lot of side effects. One important one is your laryngospasm and megaloblastic anemia. Then you have a xenon. Xenon is an inhalational anesthetic which can cause a respiratory depression. And speaking about the IV, so IV, the most important one is your thiopentone, IV anesthesia of choice, short-acting barbiturate, enhancement of GABA activity, which is an IV anesthesia of choice and neurosurgery, head injury, thyrotoxicosis. And it can precipitate delta ALA synthase, and it is contraindicated in AIP patient. Apart from that, methotrexate, which is IV anesthesia of choice, and electroconvulsive therapy, Apart from that, propofol is IV anesthesia of choice in daycare surgery, sedation in ICU, and malignant hyperthermia. And then you have a TIVA, total intravenous anesthesia. Total intravenous anesthesia. Propofol infusion syndrome means whenever propofol is infused more than 4 mg per kg per hour for 48 hours, then you may see the propofol infusion syndrome. Then you have etomidate. Etomidate is a anesthesia of choice in aneurysm surgery or cardiovascular disease. And ketamine is a IV anesthesia of choice in emergency anesthesia with a full stomach, shock, induction of anesthesia in children, induction of anesthesia in bronchial asthmatic patient. Both can cause elevated ICP and IOP, hence it is contraindicated in glaucoma and in the head injury patient. Apart from that, midazolam, which is the shortest acting one in the daycare surgery, and daycare drugs are Indian doctor makes sick people mind active. Indian doctor makes sick people's mind active. So isoflurane, desflurane, midazolam, sevoflurane, propofol, mivacurium, and alfentanil. Okay, are the drugs. Apart from that, droperidol, dopamine receptor blocking activity used for neuroleptic analgesia and neuroleptic anesthesia along with the fentanyl. Then we talked about the local anesthesia. Lidocaine is used for the regional nerve block and spinal nerve block, while bupivacaine is used for post-op analgesia and obstetrical epidural anesthesia. And esters, cocaine, and benzocaine, procaine, and chlorprocaine. Cocaine is used as a topical. Benzocaine is also topical, but cocaine is a like a reuptake inhibitor, while your benzocaine is your PABA derivative, and procaine is your along with combined with the phenylephrine, it is used for the dental surgeries. Then you have a tetracaine, which is used for the spinal and topical anesthesia. Okay, spinal and topical anesthesia. Then you have those important images. Among the important images are your Murphy's eye, oropharyngeal airway, and then you have a vein circuit, bag and valve mask, and RAE tube and McIntosh tube. Very, 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 very important MCQ. Very, 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 very important picture-based question. So with this, we have covered your anesthesia. So far, we have covered your anesthesia. So take a 15 minutes of break. So we finished anesthesia before 5 minutes. So we'll take a 15 minutes of break and see you around like 6:20. See you around like 6:20. So moving on to the second half of the session, we are going to talk about our dermatology here, people. Let me put up here. So the next area of interest is your dermatology. So here, the next topic of interest is your dermatology. Speaking about the dermatology, the very first area we are going to focus on your anatomy of your skin. The very first area we focus is your anatomy of your skin. So prior moving on to the anatomy of the skin, I want whomsoever present to acknowledge faster that if you could hear my voice and see the screen properly, type yes on the chat box. If you could hear my voice and see the screen, type yes on the chat box. If you could hear my voice and see the screen, type S on the chat box so that we can proceed, people. Okay, speaking about the dermatology. Okay, speaking about the dermatology, the first one is your anatomy of your skin. So anatomy of the skin, we are having a layers of the skin. Outermost layer is your epidermis, followed by dermis, followed by subcutaneous tissue. Okay, the outermost layer is your epidermis, and below the epidermis you have a dermis, and below the dermis you have a subcutaneous tissue. So what is the epidermis? Epidermis is the outermost skin layer which protects your underlying tissue from your infection or dehydration or any chemical or mechanical injuries or stress. Okay, so epidermis is the layer which can act like a protective layer for you. Epidermis is a layer which can act like a protective layer. And below the epidermis, you have the tough connective tissue, so called as dermis. Tough connective tissue called as dermis, which is containing a different types of cells and different types of glands. Okay, and below the dermis, you have the subcutaneous tissue, and below the dermis, you have the subcutaneous tissue, which is made up of your fat and connective tissue, which is made up of fat and connective tissue. So how many layers of the skin are there? 3 layers. What are they? Epidermis, dermis, and subcutaneous tissue. So speaking about the anatomy of your skin, the first area is your epidermis. So epidermis, we are having a 5 types of area, 5 types of layer. Epidermis, we are having a 5 types of layer. So we used to remember with the mnemonic of Californian likes girls in sting bikini. Okay, Californian likes girls in sting bikini. So we are having the stratum corneum. C stands for corneum, L stands for lucidium, G stands for granulosum, S stands for spinosum, and the B stands for basal. And the B stands for basal. So Californian likes girls in sting bikini. Stratum corneum, lucidium, granulosum, spinosum, and basal. Among that, your spinosum and basal is so called as Malpighian layer. The spinosum and basal is so called as Malpighian layer. Now, speaking about the stratum corneosum, lucidium, granulosum, spinosum, and basal, we are going to talk about each and everything. We are going to talk about each and everything. So the first area of interest, is your corneum, people. Stratum corneum. Stratum corneum. So remember, stratum corneum is absent in children or infants. Stratum corneum is absent in children or infant, especially that infant is a preterm baby or it's a low birth weight baby. Either it should be a preterm baby or it should be a low birth weight baby. Okay, so among that stratum corneum is absent in preterm baby or low birth weight baby, and stratum corneum gives basket weave appearance on hematoxylin stain. Okay, on a hematoxylin and eosin staining, your stratum corneum will gives rise to what appearance, people? Basket weave appearance. Basket weave appearance it may gives rise to. Okay, so let me highlight it here. Basket weave appearance, and here you may see it is absent in low birth weight or preterm babies. Low birth weight or preterm babies. And this stratum corneum will be removed by your epidermal turnover, and normal turnover should be 40 to 56 days. And in the case of your psoriasis, the epidermal turnover reduced to 4 days. Remember, 50 days to 4 days. So in the psoriasis, there will be an increase in the epidermal turnover, which moves from 40 to 56 days to 4 days, which moves from 40 to 56 days to 4 days. And then you have a stratum lucidium. Stratum lucidium is seen in Palman cells, and it is a transitional layer. And it is a transitional layer. Apart from that, you have a stratum granulosum, where you see the keratolysine granules are Odland bodies. Keratolysine granules are Odland bodies. You may see the stratum granulosum. Okay, and apart from the stratum spinosum, speaking about the stratum spinosum, the stratum spinosum is the thickest layer, people. Stratum spinosum is a thickest layer, and it is also called as prickle cell layer. It is also called as prickle cell layer, and this stratum spinosum contains large number of desmosomes, people. The stratum spinosum contains large number of desmosomes, and you may also see some amount of your Langerhans cells here. Some amount of your Langerhans cells here. Apart from that, it is the layer where your cholesterol is converted into 7-dehydrocholesterol. It is the layer where your cholesterol is converted into 7-dehydrocholesterol. So we are having a spinosum. Spinosum is a fourth layer, which is quite an important layer, which is also known as a prickle cell layer. Spinosum is also known as a prickle cell layer. It is the thickest layer with a massive number of desmosomes, people. It is the thickest layer with the massive number of desmosomes, and it is the Langerhans cells. You may used to see the Langerhans cells over here, and this is the area or the region of the or the layer of the skin or epidermis where you see the cholesterol will be converted into 7-dehydrocholesterol, because we studied that in yesterday's biochemistry. Vitamin D on the skin, we convert the cholesterol to 7-dehydrocholesterol, and then it goes to the liver, where it gets hydroxylated at its 25th position and converts into 25-hydroxycholecalciferol, and then it goes to the kidney, where it gets reconverted into 1,25-dihydroxycholecalciferol. 1,25-dihydroxycholecalciferol. Then you have a basal, which is also known as a stratum germinatum, where you see the melanocytes and the Merkel cells, and you may also see the intracellular organelles. You may see the melanocytes and Merkel cells, and you may also see the intracellular organelles. And apart from that, the embryological development will be happening from basal to corneum. Embryological development will be happening from basal to corneum. Then you have epidermis. So what are the cells? You may see it in the epidermis. We already talked about melanocytes, Merkel cells. You may see it in the stratum basals. And you have those Langerhans cells. You may see it in the stratum spinosum. Apart from that, you may see the keratinocyte. Apart from that, you may see the keratinocyte, which is present in the which is present in all layers. Which is present in all layers. So keratinocyte. Speaking about expanding the cells of your epidermis, keratinocyte is present in all layers, and it contains a keratin filament. Then you have a melanocyte. Melanocytes is melanocytes is present in the basal layer, especially in the stratum basal, and your melanocytes and basal cell ratio in the stratum basal should be 1:10 people. Your melanocyte basal cells in the stratum basal should be 1:10. You have to remember that 1:10. Okay, let me highlight it here. 1:10 is a melanocyte basal cell ratio in stratum basal. And you have the melanocyte which produce melanin, which will be of two types. One is your eumelanin, another one is your eumelanin, and another one is your pheomelanin. One is your eumelanin, and another one is your pheomelanin. Eumelanin produces brown or black color, people. Eumelanin produces brown or black color, while your pheomelanin produces lighter color. Your pheomelanin produces lighter color. So brown or black color is totally depend on the eumelanin, while the lighter color is totally depend on the pheomelanin. Is totally depend on the pheomelanin. Then you have a Langerhans cells. So the marker for your Langerhans histiocytosis is CD1A S207 and S100. CD1A S207 and S100. And apart from that, in the Langerhans cell, you may also see tennis racket granules or bareback granules. You may also see what? Tennis racket granules or bareback granules you may see. You should not forget it, people. You should see that tennis racket granules are bareback granules. So here it is, bareback granules. Apart from that, you have Merkel cells. Merkel cells is composed of your mechanoreceptor, which shows a tactile stimulation, and it contains a spherical granules. It contains a spherical granules. So keratinocytes contains a keratin filament, abundant in all layer. Melanocytes in the stratum basal, which is 1:10. Eumelanin, black or brown color, and pheomelanin, lighter color. Langerhans cells, CD1A, S207, and S100. And it will also produce a tennis racket granules or bareback granules. Then you have a Merkel cells, mechanoreceptor, tactile stimulation. It contains a spherical granules. It contains a spherical granules. And then you have a basement membrane. Speaking about the basement membrane, so basement membrane composed of keratin filament, hemidesmosomes, lamina lucida, lamina densa, and sublamina densa. Lamina lucida, lamina densa, and sublamina densa. So keratin filament, where you see the protein K5 and K14. What are the proteins you may see? K5 and K14 filaments you may see on the keratin filament. K5 to K14. Okay, this is not coming correct. So I'd rather use a highlighted color. K5 to K14. K5 and K14 are the two proteins where you see it in the keratin filament, and below the keratin filament where you see the hemidesmosome, and hemidesmosome contains certain proteins. Hemidesmosomes contain certain proteins. What are the proteins you may have in the hemidesmosomes? You may have the plectin, you may have the integrin, you may have the BPAG1 and BPAG2. BPAG1 and BPAG2. So plectin, integrin, BPAG1 and BPAG2 are the filaments that you may see it in the hemidesmosomes. Then you have a lamina lucida, which is also known as a salt split layer, and this lamina lucida contains laminin and anchoring filaments. Laminin and anchoring filaments. These are the anchoring filaments. These are your anchoring filaments, laminin and anchoring filament. And this lamina lucida is the weakest layer, people. This lamina lucida is the weakest layer, you have to remember. Then you have the lamina densa, which contains a collagen 4, and the sublamina densa, which contains a collagen 7. And the sublamina densa, which contains a collagen 7, also known as anchoring fibers. Okay, also known as anchoring fibrils. This anchoring fibril will attaches with the collagen fiber, and then it forms a fibroblast in the dermis. Okay, so these are the basement membrane. So epidermis, basement membrane. Below the basement membrane, you have the dermis. So basement membrane, upper part, you have the keratinocytes. Keratinocytes contains the keratin filaments. So keratin filaments which contains protein K5 and 14. What are the proteins you may see in hemidesmosomes? Which is your lectin, integrin, BPAG1 and BPAG2. And what are the proteins you may see it in the lamina lucida, laminin and anchoring filament. What type of collagen you may see it in the lamina densa? Collagen 4. What type of collagen you may see it in the sublamina densa? Which is collagen 7, which is also known as the anchoring fibrils, which is also known as the anchoring fibrils. Then you have a dermis, which is the upper dermis and lower dermis. Upper dermis is also known as the papillary dermis, and lower dermis is also known as the reticular dermis. Papillary dermis and reticular dermis. Then you have in the dermis, we are having three types of substances. One is your cellular components, connective tissue components, and ground substance. Cellular components, connective tissue components, and ground substance. And then you have the fibroblast, lymphoblast, and macrophages, mast cells, and histiocytes are the cellular component. What are they? Fibroblast, macrophage, mast cells, histiocytes, and you have your lymphoblast. You have your lymphoblast. So what type of connective tissue? Type 1 and type 3 collagen. And what type of ground substance? You have a water, electrolyte, mucopolysaccharide, and plasma protein. Water, electrolyte, mucopolysaccharide, and plasma protein. And dermis is stained for mast cell. Dermis stains for mast cells. Apart from that, you have a subcutaneous layer. Below the dermis, you have the subcutaneous layer which contains the adipose tissue and blood vessels and lymphatic. And each unit of adipose tissue with the blood vessels and lymphatic is so called as paniculus, and inflammation is so called as paniculitis. So paniculitis could be of septal or lobar. Okay, septal or lobular. Okay, what is paniculus? A subcutaneous layer which contains a unit of adipose cell along with the blood vessels and lymphatic. Unit of adipose cells along with the blood vessels and lymphatics. Then you have a hair loss pattern which contains a male contains a Hamilton pattern, while female contains a Ludwig pattern or Osland pattern. Okay, male it is a Hamilton pattern, and in the female it is a Ludwig or Osland pattern. Okay, then you have alopecia areata, where you see the patchy hair loss, exclamation sign, turning gray phenomenon, and nail pitting, and swarm of bee appearance. Swarm of bees appearance you may see. So what are the appearance you may see it in the alopecia areata, exclamation sign, patchy hair loss, turning gray phenomenon, nail pitting, swarm of bee appearance, and it is used to treat it with the steroids and contact irritant. Okay, steroids and contact irritant. So this is the image based question of your male, and this is the image based question of your female hair loss pattern. You should remember that Hamilton pattern and Ludwig or Osland pattern. Ludwig or Osland pattern. So what type of hair we are having? We are having three types of hair, people. One is your lanugo hair, vellus hair, and terminal hair. Lanugo, vellus, and terminal. So lanugo, it is a silky hair which is present in embryonic life. It is a silky hair which is present in embryonic life, and it is seen in adults with paraneoplastic condition. It is seen in adults with paraneoplastic condition. Then you have a vellus hair, which is a short, fine hair over the face, and normally it is not pigmented, and it is replaced by your terminal hair after the puberty. It is replaced by your terminal hair after the puberty. Then you have a terminal hair, which is a thick and pigmented one, used to see in an axilla, eyebrows, pubic region, except the scalp. Except the scalp, you may see this terminal hair. Okay, and growth of fingernails is 0.1 mm per day, and growth of toenails is 0.03 mm per day. Growth of toenails is 0.03 mm per day. And apart from that, each nail we used to call it as a nachium. So this is a nail plate where I'm highlighting here, people. This is your nail plate, and below the nail plate you have the nail bed. Below the nail plate you have the nail bed, and nail bed is composed of matrix, and where the nail plate attaches with the skin, that area is so called as cuticle, and the proximal area is so called as proximal nail fold, and you have the free edge, and the space between your nail bed and your nail plate is your hyponychium. Hyponychium. So the whitish shiny substance on your nail is nail plate, and below the nail plate is a nail bed, and at the inside the nail bed you have the matrix, and the point where the nail bed attaches to your skin is so called a cuticle, and proximal to the cuticle you have the proximal nail fold, and then the free edge of the and then you have the free edge of your nail, and below the free edge of your nail and your nail bed you have the hyponychium. You have the hyponychium. So here you are having a clubbing of nails. So speaking about the clubbing of nails, you have a variety of causes for the clubbing of nails, people, which is very important. Among that, you have to remember a few things: Graves, congestive heart failure, infective endocarditis, interstitial pulmonary fibrosis, pulmonary TB, cyanotic congenital heart disease, polycythemia, CML, thalassemia, methemoglobinemia, all of them is contributing for your clubbing of your nail, where you see the hypervitaminosis A, HIV infection, syringomyelia, malnutrition, nasopharyngeal carcinoma, and Maffucci syndrome, all of them can be able to produce a clubbing of nails. The very important things you have to remember for FMGE whenever the clubbing of nails are coming in, there are few things you have to remember: pulmonary TB, congestive heart failure, CML, Graves, liver cirrhosis, inflammatory bowel disease, and HIV, and malnutrition and alcoholism. These are the areas, and infective endocarditis also. These are the areas should come into your mind immediately whenever you see the whenever you see the clubbing of nails as a differential diagnosis question. So here is a slide of all the differential diagnosis of your clubbing of nails, so that you have to remember each and every portion of it, so that you can able to remember each and every portion of it and without fail. Yes or no? Okay, now speaking about the nails disorder, we are having certain important nails here. One is your Mees line. Mees line is seen in arsenic poisoning. Mees line is seen in arsenic poisoning. And Murecki's line, which is seen in hypoalbuminemia. Bewes line, which is mentioned here, which is seen in infections, pregnancies, and recovery from illness. Longitudinal red and white bands with a V-shaped neck, Darius disease. Sphincter hemorrhages, which is mentioned here. This is a sphincter hemorrhage. This is the sphincter hemorrhage. Is seen in infective endocarditis. Is seen in infective endocarditis. Now, apart from that, you have the folding, which is a pterygium. So speaking about the pterygium is seen in lichen planus, very classical MCQ. If they given you this picture, the main one is your lichen planus. Lichen planus. Apart from that, you have a cicatricial pemphigoid, and then burns, and then you have a radiodermatitis, but main one is your lichen planus. And then you have a systemic association where you see the half and half nails in chronic renal failure, half and half nails is in chronic renal failure, and terry nails in cirrhosis. Then you have a pitting of nails, nail pitting. Here you have the pitting of nails. So speaking about the nail pitting, the main one is nail pitting is seen in alopecia areata, psoriasis, where you see the oil drop sign or salmon patch. And apart from that, you may see it in the eczema. So pitting of nails and is seen in alopecia areata, psoriasis, and eczema. Okay, then you have a periankle fibroma. Speaking about the periankle fibroma, which is seen in tuberous sclerosis, people. Periankle fibroma is seen in tuberous sclerosis, and onycholysis is seen in psoriasis and onychomycosis. Then you have a glands. You have a sebaceous glands. Area of distribution of your sebaceous gland is your scalp, followed by interscapular and sternal areas, which is active during puberty. And apart from that, you have a sebaceous gland with the hair follicle, we used to call that as pilosebaceous unit, people. We used to call that as pilosebaceous unit. Then you have a sweat gland, which is an eccrine and apocrine gland. Eccrine is seen all over the body, while your apocrine is seen in the hair follicle, which is seen in the hair follicle, while the disorders such as anhydria, hyperhidrosis, and malaria are associated with eccrine gland, while the disorders such as bromhidrosis, chromhidrosis, Foxpot disease, and hidradenitis suppurativa, all of them are seen in the apocrine glands. Okay, all of them are seen in the apocrine glands. Then you have a sebaceous gland disorder. There are two disorders we are going to discuss over here. One is your acne vulgaris and rosacea. Speaking about the acne vulgaris, which is the most common form of acne, which is treated by isotretinoin, and most severe form is so-called as acne conglobata, and most severe form of acne vulgaris is grade 4, which is so-called as acne conglobata, and most characteristic lesions you may see in the acne vulgaris is comedones. Okay, so acne vulgaris is the most common form, and among that most characteristic lesion is your comedones, and most common or most severe form of acne vulgaris is grade 4, and most severe form of acne is acne conglobata. Drug of choice is isotretinoin. Isotretinoin, while it may causes diffuse interstitial skeletal hyperostosis. Diffuse interstitial skeletal hyperostosis, which is so called as DISH. Okay, which is the most severe form. Apart from that, you have a rosacea, cutaneous flushing on the work in a hot areas, or maybe drinking coffee. After that, he may have a cutaneous flushing, that is so called as rosacea. So this is all about the sebaceous gland disorder. And apart from that, sometimes you may have a ectopic sebaceous gland disorders. One is on the lips, you may see the Fordyce spots. Glands, you may see the Tyson gland. Eyelid, you may see the Meibomian gland and the gland of Zeiss. And areola, you may see the Montgomery tubercle. And on areola, you may see the Montgomery tubercle. Then you have a skin lesion, macule, change in pigmentation of the skin less than 0.5, patch more than 0.5. So you see the layers whenever the skin is matching with the lesion layer. There is no elevation or no depression. Then you look for the size. If it is less than 0.5, then it is so called as macule. If it is more than 0.5, then it is so called as patch. Then it is so called as patch. Now consider the lesion is elevated. Consider the lesion is little bit elevated over the skin. This is the skin and the lesion is little bit elevated. Then you have to look for the size again. If the size is less than 0.5, it is a papule. If it is more than 0.5, it is a plaque. So we are seeing, we see the skin lesion and we see it along with the level of the skin. If the skin level is coinciding with the, like lesion level, and there is no elevation or depression, then you see on the top, you see the color change. Whenever there is a change in the color change, then you measure the size. If it is less than 0.5 centimeter, then it is a macule. If it is more than 0.5 centimeter, then it is a patch. Then you see there is an elevated lesion. That was a solid one. If it is a solid and less than 0.5, it is a papule. If it is a solid and more than 0.5, it is a plaque. If it is a solid and more than 0.5, it is a plaque. Then you look at the lesion, whether it is fluid filled or not. Elevated lesion with the fluid, then you look for the 0.5, 0.5. If it is less than 0.5, then vesicle. If it is more than 0.5, then it is a bulla. Then it is a bulla. Then you see if there is any blood or not. If the lesion is a blood, or if the lesion is containing any sort of like what do we call it, like a blood point or red color, then you see that there is a pinpoint bleeding on there. Then look at the size. If it is less than 0.3 centimeter, it is petechiae. If it is more than 0.3 centimeter, it is purpura. It is more than 0.3 centimeter, it is purpura, but the purpura size should be 0.3 to 1 centimeter. If it is more than 1 centimeter, then we used to call that as ecchymosis. Then we used to call that as ecchymosis. Then we have a telangiectasia, where you see the visible dilation of blood vessels. And if the vesicle is filled with the pus, then it is a pustule. And if the skin, we find a solid lesion, but the solid lesion was deep and more than 0.5, then we used to call that as nodule. Then we used to call that as a nodule. You see the solid lesion and a deep lesion, then it is a nodule. Then if the defect in the skin involving more than superficial dermis, then it is an ulcer. Then if you see the necrotic lesion, then it is a eschar. Then it is a eschar. So how do you identify the skin disorder, people? Look at the level of the skin and look at the lesion. If the level of the skin and lesion is same, only the color has been changed, then look at the size. If it is less than 0.5, it is macule. If it is more than 0.5, it is patch. Then you see there is an elevated lesion. Then you see there is a elevated lesion. Check whether it is having any, it is a solid lesion or fluid filled lesion. If it is a solid lesion, then you have to look for whether it is a deep or superficial. If it is a deep and more than 0.5, it is a nodule. If it is deep and more than 0.5, what it is? Nodule. If it is superficial and the solid lesion is less than 0.5, then it is so called as papule. Then it is so called as what? Papule. If the lesion is more than 0.3, 0.5, then we used to call that as a plaque. Then you used to call that as plaque or plaque, however you call it. Okay, this is a solid lesion. Elevated lesion with a solid lesion. Now you press it and it is pressing. You see there is a fluid inside. Then look at the size. If the fluid is less than 0.5, it is a vesicle. More than 0.5, it is a bulla. And if it contains a pus, then it is a pustule. Then if it contains a blood, depending upon the size of the blood, we have a different name. Okay, now we see the blood. Blood-filled lesion. Look at the size of the blood-filled lesion under the skin. You see the pinpoint red, right? Yes or no? If the bleeding points are there less than 0.3, it is a pitake. If it is 0.3 to 1, it is a purpura. If it is more than 1, then we used to call that as ecchymosis. Then we used to call that as ecchymosis. Then if it is crossing a superficial dermis, then it is an ulcer. If you see the necrotic lesion, then it is a eschar. Then it is a eschar. So these are the important skin lesions that you may have an interpretation, people. Okay, they may give you any of this picture and they may ask you what type of lesion it is on the picture base. That's why I added a picture also here. But mainly you have to remember, you have to differentially diagnose whenever you see the lesion, whether it is a macule or patch or papule or vesicle or bulla or nodule, petake or purpura or ecchymosis or telangiectasia or pustule or ulcer, anything you can able to differentiate by seeing the picture itself. You should say and you should know why we used to name it. Okay, then we are having a secondary skin lesion. Speaking about the secondary skin lesion, scale, plate-like exciseration of your flaky exfoliation, plate-like exciserance of your flaky exfoliation. You may see it on the stratum corneum. That is so called a scale. Here is the image of the scale, people. Behind the scale, below, next to the scale, we have the crust, which is a solid consolidation. Then you have a lichenification, where you see the thickened rough epidermis with accumulation of your skin markings. And apart from that, you may see the excoriation, loss of epidermis, and erosion, discontinue of your epidermis, and you see the fissure. Fissure means what? Crack. Crack in the epidermis or dermis, it is so called as fissure. Then you may see the atrophy, reduction in the skin thickening is so called as atrophy. And then you have a scarring, and scarring means like like a hard plaque of your fibrotic tissue will form over the epidermis, and then it appears very prominently. Sometimes it may be atrophic or sometimes it may be the hypertrophic one. Then you have a vegetating, lushly growing process, which is usually elevated one, that is so called as vegetating lesion. These are all the secondary skin lesions. Among the secondary skin lesion, the important ones are your lichenification, where you see the rough epidermis along with the skin markings. And apart from that, you may see the erosion, discontinue of your skin with the loss of epidermis. And then you may see the scarring. It could be a healed wound or it could be a keloid wound. The scar will be hypertrophic or atrophic. Hypertrophic scar means it will form a keloid. Yes or no? So keloid wound, maybe they may ask you as a pictured question. They may ask you as a picture-based question. You need to answer it. Okay, you need to answer it. So here are some of the important images that you have to know. And these images contributes for about 2 to 3 marks in your FMGE. So you have to make sure that you know all the images. You know all the images, and once you complete the images, we complete our dermatology section. We complete our dermatology section. Okay, fine. Now the first lesion is your erythema multiforme, where you see the target lesions along with the blanching center. So here you may see the target lesion along with the blanching centers, target type of lesions. So here you see, this is a target lesion, right? Yes or no? This is target lesion. So you see the target type of lesion here along with the blanching center or blanking center. This is seen in erythema multiforme. Erythema multiforme. So important image. Then you have a tinea corporis, which is a ringworm infection, usually presents with the scaly pruritic patch with the central clearing. Scaly pruritic patch with the central clearing. Along with that, you may see there is an active border. Along with that, you may see there is a active border. Scaly pruritic patch with the central clearing. Along with that, you may see the patchy border. Pruritic patch along with an active border. Okay, that is so called as tinea corporis. Tinea corporis. And the next image we see here is your erythema toxicum neonatorum. Erythema toxicum neonatorum, where you see a benign self-limited eruption which is occurring primarily in healthy newborns, in the early neonatal period. Okay, early neonatal period, and it is characterized by your blotchy red spot on the skin. You see there is a blotchy red spots over the skin, along the cheeks. It will be followed by your white or yellow papules or pustules. It will be followed by the white or yellow papules or pustules. Here in this baby, you may see there is a yellow pustule here. Here you may see it in this baby, there is a yellow pustule here. You see this? This is a erythema toxicum neonatorum, ETN. Erythema toxicum neonatorum. Then you have this here, segmental vitiligo. So, you know, like a localized vitiligo patient will have this vitiligo pattern. So this pattern is forming a dermatomal distribution. So it could be either a unilateral or asymmetrical. Okay, it will be a unilateral and asymmetrical. It follows a dermatome course, and you may see the decolorization or depigmentation over here. You may see what? Decolorization or depigmentation over your particular area of your dermatome, or particular dermatome will be affected here. This is so called as segmental vitiligo. And here neurofibromatosis usually affects with a lot of things. So NF1 and NF2 type, you have to remember that. Picture of neurofibromatosis skin lesion. And apart from that, active eczema, here is your eczema. So rapidly forming your red rash, which may be blistered and swollen. Here you may not see the blisters, but you may see the swellings. You may see the swelling. Then you have a ectopic sweat gland disease, which is your Ford spot, where you may see it over the lips. This is your Ford spot. Whitish yellow bumps that can occur on the edge of your lips or inside your cheeks. Okay, edge of your lips or inside your cheeks. Here you may see whitish yellow bump. Here you may see it. Then you have arterial ulcer, which is caused by the ischemia. It is a painful condition. They often form it on the outer side of your feet or on the toes. Very, 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 very important. Okay, arterial ulcer, mostly due to the ischemia. Okay, then you have a discoid Lupus erythematosus, DLE rash. Same like, red inflamed patch, which is scaling and crusty appearance. Here you may see the DLE type of rash. Okay, rash, you may see it on the DLE. And here you may see the borderline lepromatous leprosy, where you may see the numerous symmetrical small macules, papules, plaques, and nodules. Okay, all type will be there in the borderline lepromatous leprosy. Apart from that, in the severe form, you may see the leonine phases. You may see it in the Leonin facies. Apart from that, this is a chirion. This is a chirion, an abscess which is due to the fungal infection on your scalp. That is so-called as chirion. And then you have a chromoblastomycosis, which is a chronic fungal infection of your skin and subcutaneous tissue. This is a classical picture they may ask you with the chromoblastomycosis. Then you may have this ulcer cruris, which is due to the, unhealed wound. You may see that in the ulcus cruris. And apart from the cherry angioma, bright red angioma or mole-like lesion on your skin, which is made up of your blood vessels or capillaries. Bright red skin growth made up of small blood vessels or capillaries. Very, 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 very common. Cherry angioma is very, very common. If instead of red, if you see the black, then it is a melanoma. Then it is a melanoma that can be beginning with the melanocyte, which is seen in the stratum basal, where the melanocyte basal cell ratio should be more than 1:10, where it is more than 1:10. Then you have a verruca plana. Verruca plana is a flat wart. You may see it in the cheek, around the cheek region, and it is a grayish, and sometimes it will be hyperpigmented one. Sometimes it will be the hyperpigmented one, and it is a slightly elevated papules you may also see. So grayish discoloration along with the slightly elevated papules, you may see it in the verruca plana. You may see it in the verruca plana. Then you see the mucosis fungoides here. It is a mucosis fungoides, which is due to the, which is also known as your Alibert-Bazin syndrome, caused by granuloma fungoides. And it is a most common lesion of your cutaneous T-cell lymphoma. Very, 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 very important. Either the mucosis fungoides will be given here like this similar image, or they may given anywhere in the body. Okay, anywhere in the body. That can, but they give the history of cutaneous T-cell lymphoma. But they give the history of cutaneous T-cell lymphoma, they may give you. And apart from that, you have the scalp psoriasis. So speaking about the scalp psoriasis, it appears as a silvery red scales, and it may extend beyond the hairline. It appears as a silvery red scale and extend beyond the hairline that can cause itching, flaking, and redness. This picture is one of the important picture that you should not miss, people. This picture is one of the important picture that you should not miss. Then you have a chancroid, dermatological manifestation of your chancroid, and then you have a donovanosis, and then you have a herpes ulcer, and then you have the herpes ulcer. So these are the image-based question which has a highest, potential to come on your exams. So you should not miss it, people. You should learn it completely. Okay, you should learn it completely, which was given on your survival kit. Don't miss it. Okay, don't miss it. Remember that. Don't miss it, and you can able to finish off those things. Okay, and you can able to finish off those things. You should not miss it. Okay, clear about that? So far we have done this. So far we have done the dermatology section. So far we have done the dermatology section. So among that, what are the important areas you have to know is your anatomy of your skin, especially what type of cells, where you see Baerberg granules are seen in. Tennis racket or Baerberg granules are seen in Langerhans histiocytosis. Okay, where the marker is S207, S100, and CD1A. And CD1A. Apart from that, protein K5 and K14 are present in keratin filament. Plectin and integrin and BPAG1 and BPAG2 are present in your hemidesmosomes. And then you have a salt split layer is seen in lamina lucida, and you have the collagen 4 is seen in lamina densa, and you have collagen 7 is seen in your sublamina densa. Okay, is seen in your sublamina densa. So most of these things are mentioned here. All the image-based questions is also mentioned here. Among that, very, very important MCQ is your psoriasis of your scalp, mucosis fungoides, chancroid, herpes genital ulcer, carrion, and you have this You have this lesion, DLE lesion, neurofibromatosis, and tinea corporis. All of them are quite important images that kind of like most anticipated images also. You should know that too. Okay, so far we have completed this dermatology and anesthesia today. So today is a slow day for you. So read out in a very fast manner and cover up your anat, physio, biochem along with this. And tomorrow we will move on to your secondary subject, second year subject like a patho, micro, and pharma. So when we move on to your second year subject like a patho, micro, and pharma, that's the time where we used to have a lot of things to be discussed, and you need to remember a lot of stuff. Okay, especially when it comes for the pathology. Okay, so we will do it in the upcoming sessions, and then PSM will be separated into two parts. Okay, where we will be discussing a one part one day and another part on the second day. Okay, so far this is all about your anesthesia and dermatology. So far we have covered your anatomy, physiology, biochemistry, anesthesia, and dermatology. All the sessions were in the YouTube. You have to learn it properly and read it. And this is kind of like a showstopper for you, where you expect to see a lot of questions, people. Lot of questions. This was a very compiled information that you have to remember. Okay, all the very best, and see you all tomorrow again with the new subject. Thank you.